Hello, everyone. I would like to welcome everyone to this year's last CME presentation and the third of the CME quarterly series on lysosomal disorders. It is my pleasure to welcome our guest speaker, Dr. John Bach, who has actually a treat for all the attendees and who's going to be watching the CME video afterwards. As an introduction, I would like to first start with the lysosomal disorders, actually that present as pulmonary diseases. Let me share my screen first. Hold on a second. Are you able to see this or no?
Not yet, no.
Yeah, I think this is better now. Is that right?
Yes, thank you.
Okay, all right. Sorry about the inconvenience. So we're going to be covering the pulmonary manifestations of lysosomal diseases. So the main topic is how to assess patients, monitor, and manage and treat the ones that come with a pulmonary disorder. So the reason that pulmonary system is not too much in mention is because pulmonary system is not primarily involved in lysosomal disorders. So when you go to the textbooks or Google whether the pulmonary system is primarily involved, we actually came into mostly the sphingolipidosis. So as presenting as interstitial lung disease, when you get an X-ray, it is typical is basically in ground glass appearance in a child or in an unsuspecting adult. So if you want to do a differential diagnosis with this X-ray and for a patient who is suspected lysosomal disorders, then the primary diseases that we're going to be looking into, Gaucher disease, this is the neuronopathic Gaucher disease more prominently, this Niemann-Pick AB, Farber disease, and Fabry disease. Actually, Fabry disease can present as interstitial lung disease, not as a primary manifestation, but obviously as a comorbidity. The second scenario is the lungs are normal, and however, there is lung disease secondary to the involvement of the muscles of the respiratory system that includes the diaphragm, which is a big muscle, and also other accessory respiratory muscles. And the third way how the airway and respiratory system is involved. So basically the soft tissue infiltration accompanied by limited chest mobility, and mucopolysaccharidosis is the prime example for that. If you want to dig into a little bit more into pulmonary interstitial disease and the pathophysiology of that, actually this X-ray appearance is by pathology is accompanied by infiltrative or inflammatory cells invading the tissue in the upper side that you are seeing the CT scan that is actually very pathognomonic for interstitial lung disease, even though the X-ray is not doing the justice. Actually, you are seeing this hazy appearance. And in the postmortem studies, you can see the immune cells, which is the Gaucher cells here in the perivascular space, in the interstitium, and rarely at the alveolar space. And actually, that is probably the terminal event in a patient with Gaucher disease. When we talk about the secondary pulmonary involvement, so basically this is the complication of the disorder. So obviously hepatosplenomegaly or having a huge liver and spleen will decrease the vital capacity of the lungs. So even though lungs are normal, you can get restrictive pattern in a breathing test. So obviously similarly spine, it's like progressive kyphoscoliosis that occurs in Gaucher disease or in MPSs. Also, the chest deformities, pectus carinatum, excavatum, actually can give the restrictive pattern on the PFTs, and obviously secondary cardiac disease that occurs in Fabry disease and PSS, and similarly recurrent infections and aspirations can give rise to chronic lung disease, and more rarely we can actually evaluate the patient for pulmonary hypertension as in type 1 Gaucher disease, or due to chronic respiratory failure in patients with Pompe disease. So even though we don't usually deal with a patient on a respiratory support, meaning as a geneticist I am, but it is not uncommon for the patients to be on ventilatory support and even have tracheotomies, which any disorder that has a progressive neurological disease, and that includes Gaucher disease, Tay-Sachs, so on and so forth. And when there is central apnea, stridor, or laryngeal dysfunction, like in Gaucher disease, or there is progressive diaphragmatic or accessory respiratory muscle dysfunction, like in Pompe disease. So I don't want to actually have the audience take more time, and I would like to go ahead and introduce Dr. Bach, who is a leader in helping patients with various neuromuscular diseases to breathe effectively. Dr. Bach has received his medical degree from the College of Medicine and Dentistry of New Jersey, and had extensive training in pulmonary rehabilitation and non-invasive mechanical ventilation. And he's currently a professor of physical medicine and rehabilitation at Rutgers, New Jersey Medical School, as well as a professor of neurology and medical director at the Center for Non-Invasive Mechanical Ventilation. So he has authored more than 200 publications on the respiratory issues in both lysosomal and neuromuscular disorders. And he also has 7 books on neuromuscular pulmonary rehabilitation and non-invasive mechanical ventilation. Today, Dr. Bach is going to share some of his experiences in helping people with neuromuscular condition like Pompe disease lead breathable lives. Thank you. Thank you, Dr. Bach. The podium is yours.
Oh, yeah, I'm trying to, you hear me, I think. I'm trying to share my screen. I'm clicking, oh, here we go. All right. This is what I have on my shared screen. It's not ideal. If you have an idea of how I can increase the size of this, would be helpful. Is this all right? Yes. Ozlem, is this all right?
I guess.
That's fine.
All right. Okay. So let's get started. And that's a wonderful introduction. A really wonderful introduction to this, because I'm going to explain that it's extremely important to distinguish people with intrinsic lung disease from people who have potentially normal lungs but have muscle weakness, and other people with airways disease, and also people with upper motor neuron disease. And you'll understand why as we get into this. I have no conflicts of interest to declare. You're going to also learn something that, well, Ozlem, nobody ever needs a tracheostomy tube for being too weak to breathe. And we'll go over this. Now, I'm not going to spend time on the basics of lysosomal storage diseases. I guess I could say that technically Gaucher is the most common at 1 in 40,000. It's estimated that there's 1 in 7,000 of the population that has these conditions. But some of the conditions, as you said, affect the lungs intrinsically, and others, basically the diaphragm and the respiratory muscles. Now, I have my most experience with Pompe disease. I've got 14 basically adult onset Pompe patients and several with Morchio. So that's where my experience lies. And we will, I'm going to want to talk about the respiratory management of these patients. I'm sure you all know how to make the diagnoses at this point. I will tell you that several of my Pompe patients had been diagnosed with limb-girdle muscular dystrophy, and it turned out that they did not have that. And one of the first indications that there was something funny going on with the diagnosis was the fact they couldn't breathe lying on their backs. So it's classical for all of my basically adult onset Pompe patients that we initially expected this or to search for it because the patients could not breathe lying on their backs. And the reason they couldn't, their vital capacities went down drastically when they lie on their backs because their diaphragm was weak. This is not recognized by pulmonary function testing. Pulmonary function testing is virtually useless for the diagnosis of any muscle weakness condition. The vital capacity sitting, excuse me, I'm at a lecture, I can't talk now. The vital capacity when you're sitting is not nearly as important as the vital capacity when you're lying down. Because the difference between the two should not be more than 7%. But when patients get short of breath lying on their backs, the difference can be as much as 80%. And this is completely missed by pulmonary function testing. Likewise, I'm going to tell you that sleep studies are not important either. I have 3,000 patients on non-invasive ventilatory support. I haven't had to order polysomnograms on any of them. And I'll explain to you why. You'll understand before this is finished. So, so 1 in 40,000 Gaucher's disease. Pompe was described in 1932, acid alpha glucosidase deficiency, but you know all of this. Okay. You will learn how to prevent ventilatory or respiratory failure and any need to resort to tracheotomies for lysosomal storage disorders that are not predominantly intrinsic in nature, which I have never seen one that was. You can have infiltrated disease in Gaucher's and Fabry's and so on, but the primary problem has usually been muscle weakness from the diaphragm, infiltration of the diaphragm and other respiratory muscles. So what I like to do is describe Pompe's and other neuromuscular conditions in terms of type 1 through type 3 or type 4. So, and I got this idea from SMA because children with spinal muscular atrophy type 1 never sit, and they usually stop breathing during sleep between 5 and 8 months of age because their muscles are weak. And they also have paradoxical breathing, whereas their diaphragm goes down, their belly goes out, but their chest wall sinks in. That's paradoxical breathing. Now, I can tell you right now, with Pompe disease, infantile Pompe disease, or any neuromuscular condition where there's paradoxical breathing, if you do not reverse the paradoxing during sleep by placing the patient on ventilatory support settings to reverse the paradoxing, the lungs will not grow and the patient is going to die pretty soon. They need ventilatory support settings to rest their muscles overnight so that they're stronger during the day, but also to reverse paradoxing. Now, I consider type 2 disease to be, well, in SMA, it's children who can never sit. But in any infants with congenital myopathies, Pompe, or anything else, you have children who cannot sit. I'm sorry, with type 1, they don't sit. With type 2, they can sit independently. However, there's type 2A and 2B, depending on if they have paradoxical breathing or not. So, in other words, any child with any neuromuscular condition with severe muscle weakness who has paradoxical breathing. Now, in case of SMA, it's all type 1s, and it's half, literally 50% of type 2s, they have paradoxical breathing. They need to be on nighttime ventilatory support to expand their lungs and reverse the paradoxing, or their prognoses are terrible. Excuse me, I'm sorry, I'm lecturing, call back. Oh, I'm sorry. Now, with type 2B disease, patients don't have paradoxing, and they usually do not need ventilators overnight. With all these types, including type 3, where children can walk for a period of time, as occurs with Pompe disease, childhood onset Pompe disease. Even when these kids have type 3 condition, their cough flows may be ineffective. So, for example, there are children with type 2B and type 3 neuromuscular conditions, including Pompe, who do not need ventilators, except when they're sick. When they're sick, they need non-invasive ventilatory support 24 hours a day for the time that they're sick. Now, the problem in the United States is it's very difficult to do this because the insurance companies often want 3 or 4 days to approve a ventilator. But of course, these kids get short of breath without the ventilator and without what was called a cough assist for mechanical insufflation, exsufflation, which I will describe. And so they go to the emergency room. Now, when they go to the emergency room, when you or I or anybody goes to the emergency room with any respiratory symptoms, the first thing that is done is that we're given oxygen. But that does not solve the problem. The oxygen saturation is going down, not because of hypoxic respiratory disease. It's going down because the patient's not able to clear their secretions and ventilate their lungs to a normal CO2. That's usually what the problem is. And it's only worsened by getting oxygen. So the first thing that people taking care of Pompe, of lysosomal storage disorders need to understand is you need to distinguish if the primary symptomatic problem is from intrinsic lung disease, which frankly I have never seen, although I'm sure it exists, and is usually perhaps cared for by pulmonologists, or if the problem is muscular, predominantly muscular, in which case giving oxygen is pretty much the worst thing you could do until you actually intubate the patient. So again, in children, whether they can sit or walk or not, if they have a neuromuscular condition where it prevents them from running, if a child can run, they probably have adequate cough flows. But the cough flows in type 1 and type 2A disease are essentially zero. And the mild cold will cause pneumonia for that reason. In type 2B disease, cough, and type 3 disease, the cough flows are not ideal. Some kids can get over colds without getting pneumonia, but it's extremely difficult, and all these kids should have access to mechanical insufflation, exsufflation. Now let's go on. This is a child with Pompe disease. You see the head lag. This child has severe paradoxical breathing. Now, enzyme replacement therapy in infants with Pompe disease that I have seen work, but they can triple the life expectancy. But usually these kids die from heart failure, even at 1 or 2 years of age. We can prevent respiratory deaths 100% of the time by doing what we do. But in infantile Pompe, we cannot prevent cardiac deaths. In contrast with adults with Pompe, usually their hearts are not significantly affected at all. And they can go into cor pulmonale from bad pulmonary management. So that's another system. So this is a type 1 condition. And how we ventilated these children before nasal interfaces were on the market was by taking Hudson CPAP prongs, putting them through the nasal bridge of a CPAP mask, the foam that you see here, to seal the nostrils and ventilate the child's lungs to expand them to reverse the paradoxing. And this provides full ventilatory support for when the child needs it, or the adult needs it for that matter. We'll go into that. And also rests the muscles overnight. BiPAP doesn't do this because for decades, BiPAP was prescribed at spans of 4 to 6, which is well, we'll talk about that in a minute. This is the other thing that you're going to learn is that nobody ever needs to be trached for being too weak to breathe. That includes children with SMA type 1 and infantile onset Pompe disease, of which this child, for example, was intubated at 17 days of age, totally unweanable in ventilatory failure at 17 days of age. He failed 2 extubation attempts, and the doctors wanted to trach him, but the mother knew about us, so told the doctors to call me, and I explained how to extubate this child. But basically, what they try to do is extubate the child to oxygen and BiPAP, and that's a good way to fail. We extubate the child to full non-invasive ventilatory support, nasal ventilatory support, like you see here. And this child, they succeeded, which is remarkable because most of the time, critical care doctors don't want to hear anything about this. They just want to trach the kid and send them to an LTAC or to another institution so that the complications that will eventually kill the child are not their problem. So harshly put, but it's honestly true. So anyway, this child was successfully extubated and eventually came off the ventilator and was able to sit with enzyme replacement therapy. Signs and symptoms of infantile onset Pompe disease, as I think you know, basically it's cardiopulmonary is why these children die. And like I said, we can't do so much for the heart, but we can prevent respiratory problems. Now, this is a patient with Morchio. I believe he's 32 years old, one of our patients with Morchio. And his history is really very interesting because it's really typical. I consider him to have neuromuscular condition type 3 because he was able to walk until he was when he was 2.5. He was born in 1984. He was floppy at birth, diagnosed by biopsy, skin fibroblasts. In 1990, at the age of 6, he got pneumonia, was hospitalized and intubated, unweanable, transferred to us to be extubated. That happened again 2 years later when he was 8. So in other words, he was hospitalized locally in New York State. He would have been trached and he would have died from 50 to over 80% of patients on trach ventilation with neuromuscular weakness die because of the trach tube, not directly because of their neuromuscular condition. This is kind of amazing when you think about it, and it's very different from lung disease because when a person presents to a doctor with COPD and their FEV1s, their forced expiratory volume in 1 second, is 750 or less, their 5-year prognosis for survival is only 30%. That's worse than many cancers. So if they get trached, they often don't die from the trach tube. But I have patients now on 24-hour non-invasive ventilatory support since coming out of Iron Lungs in 1954, 70 years of continuous ventilatory support with no ability to breathe whatsoever and no tracheostomy tube. I have 18 patients with spinal muscular atrophy type 1, 0 vital capacity. They are 18 to 30 years old with no muscle movement whatsoever, no muscles above or below the neck, yet they don't have trach tubes. You cannot get weaker than that. It is impossible to get weaker. The only thing they can move is an eye, and one of them can move an eye and the eyelid. Others cannot even open their eyelids. You have to open the eyelid and ask them yes or no, left and right. They can't move their tongue a millimeter. They don't have a finger. They don't have any even trace muscle movement. And yet they're up to, I have 3 of them over 30 years old now, like this. And the only way they can communicate is with the eye movement through their computer. So if that's the case, nobody with Morchio or any lysosomal storage disorder that causes muscle weakness should ever need a tracheostomy tube. And they won't need it if they come to us, I'll tell you right now. In fact, I guarantee to my patients the first time I see them that you will never need a trach tube. And don't let any doctor convince you to get one because it'll probably kill you. And quite frankly, that's the case. So what was done was the child was extubated successfully to 18 centimeters of water pressure, inspiratory pressures, 18 and 0. And did fine. This is the Morchio patient. We extubated him to full ventilatory support. Now, if you or I need general anesthesia and we go to an anesthesiologist and we say to them, well, while we're under with a neuroparalyzing agent, we essentially have 0 vital capacity. And how do you ventilate my lungs? If you give me a normal tidal volume, what pressure do you need to give me? They'll tell you 17 to 20, 22 centimeters of water. So obviously, that's what you need to rest your muscles and to give you a full breath if you cannot breathe at all. Or they could, of course, give you 500 or 600 milliliters of air, which will create a back pressure of 18 centimeters of water. It basically comes out the same. So why, in heaven's name, when a patient is intubated or trached, and if you look at the PIPs, the positive inspiratory pressures on the ventilator, they're 18 to 20 centimeters of water, why do critical care doctors extubate these unweanable or these very, very weak patients to a BiPAP of 8 and 4 or 10 and 5, which is a pressure support of 5? And then when they fail the extubations, say that, well, NIV didn't work, so we had to trach them. This is absolute nonsense. NIV never fails. In fact, I don't use NIV. Non-invasive ventilation is having a fan, a ceiling fan in a hot room, or using CPAP, which is a continuous flow of air, which is a pneumatic splint to keep the airway open. So you could use your muscles to breathe. But if the problem is that your muscles are too weak for normal ventilation, the CPAP is completely useless, yet it's called non-invasive ventilation. In 1990, because there were so many people overweight who couldn't really breathe and had obesity, hypoventilation, but when they increased the CPAP to 20 or 30 centimeters of water, is like breathing in a tornado, they developed BiPAP. BiPAP, you get the air when you inhale at a higher flow than the air stopping you from exhaling. However, the only way to ventilate severely morbidly obese patients, 400-pound patients, to a normal CO2 is not with the pressure support of 18 to 20, but with an inspiratory pressure of 55 centimeters of water, 35 to 55 centimeters of water, which means that if you give them EPAP of, say, 10, you've got to increase the IPAP by that amount to get the CO2 normal. And it's not true that patients should be breathing with CO2s of 60. They're only going to go into cor pulmonale and die from heart failure. We ventilate 400-pound patients here without trach tubes. We even take their trach tubes out when they have them on pressures of about 35 to 40 centimeters of inspiratory PIP, positive inspiratory pressures, to normal CO2s, get them off of oxygen, and they never need trach tubes. So with lysosomal storage disease, you don't need pressures of 20 or not pressures of 30 or 40 or 50 centimeters of water, unless there's severe restriction on the lungs. Now, is there a limit to how you can use non-invasive ventilatory support settings? Well, we do use them on patients with restrictive lung disease from severe scoliosis and morbid obesity to pressures of 40 centimeters of water. However, if you're extubating somebody and you need pressures like that, there tends to be a lot of leak and sometimes, well, difficulty training patients how to use non-invasive ventilation when their lungs are that stiff. I guess I'm getting off of the subject of this patient here. All right, so he was transferred twice to us because he's unweanable and intubated. We extubated him. We've had him on nighttime ventilation since he was about 6 years old. Since he was 6 years old, he had scoliosis surgery when he was 14. We extubated him to full ventilatory support, which was a bi-level of 22 and 4 for a pressure support of 18, 22 minus 4. In January of 2004, his vital capacities were varying from 580 to actually about 1,000. Now that we do sitting and lying down. Lying down was lower. Somebody in July of 2015, somebody put him on BiPAP. He was doing so well, he didn't come to see us for a few years. He was on a BiPAP of 12 and 8 with an AHI of 77. We, of course, stopped that and put him back on 22 and 4. Now, normally, we switch patients to active circuits so we could shut off the EPAP, and I'll tell you why very soon. But on 22 and 4, his apnea-hypopnea index became 0. He was getting full pressure ventilation and was doing very well with normal blood gases day and night. He started replacement therapy in December of 2015. Now, interestingly, even though he got to require ventilator use day and night, every night, and for many periods during the day till he was actually using it most of the day. And even though his vital capacity has not gone up tremendously since he began replacement therapy, his vital capacities have improved a little bit, and he no longer needs to use the vent during the day, and his manual muscle testing is slightly better. So the replacement, I am totally convinced that there, as I am with some of my adult patients, that the replacement therapy has been very beneficial for him. His left ventricular ejection fractions are normal. He has an AV block, some mitral thickening, but interestingly too, with the replacement therapy, he lost the ability to walk at the age of 2.5. But then 4 years after starting replacement therapy, he started walking again, and he has been walking ever since. He can still take some steps. So that's one of our several Morchio patients, and he's bright. He does have hearing deficit and seizures, so he's sort of a classic Morchio individual. Well, again, it's cardiac and pulmonary that we're concerned about. Of course, with lysosomal storage diseases, the GI tract can be involved, the spleen, but you know all of this, and I don't really want to go into that. Enzyme replacement therapy. Okay, so now, this is crucial. One of the questions asked was about what pulmonologists need to do about this or need to know. Fact of the matter is, pulmonologists treat lung disease, they don't treat muscles. And when they try to wean people in critical care units, they do it by synchronized intermittent mandatory ventilation and decreasing pressure support, which means that the patient never gets full rest. It's like lifting weights at 70% of your maximum capacity and never resting your muscles. When you treat muscles like I do, if you want to make them stronger, you've got to rest them and exercise them, not continually use them at sub-maximum capacity levels. That can just make them weaker. So pulmonologists really end up tracheing all these patients because when they're unweanable, they think they need to be extubated to a trach tube. That is never the case. So number one, you got to distinguish the patient with ventilatory pump failure who cannot cough effectively or breathe to a normal CO2, and from muscle weakness, like these diagnoses I have here, including morbid obesity, chest wall disease, spinal cord injury, and so on, where there's an increased work of breathing, from upper motor neuron diseases. Now, what do I mean by that? I mean people with traumatic brain injury, stroke, cerebral palsy, Lou Gehrig's disease, ALS. When you have upper motor neuron disease, the upper airway tends to close. So on babies with type 1 neuromuscular disease, when I use mechanical inexsufflation on them at 50 to 60 centimeters of pressure, mechanical inexsufflation is like a vacuum cleaner. It delivers a deep breath, but then the pressure drops from plus 50 or 60 centimeters of water to minus 50 or 60 centimeters of water. And I use these pressures on infants as well as on adults. I know what you're thinking. Aren't you afraid of barrel trauma? It doesn't happen. The way we use it, it just doesn't. And the pressures in the lungs are not 60 centimeters of water. But at any rate, when you use those pressures like applying a vacuum cleaner to the airway, non-invasive suctioning, it creates 10 liters a second of flow to bring secretions up from the right and left airways. Now, if you suction through a trach tube or a translaryngeal tube, up to 92% of the time, you don't get the left mainstem bronchus. It goes into the right airway because of anatomical reasons. The tube just goes in, down the trachea into the right airways, which is why over 80% of pneumonias in these patients are in the left lung. When you use mechanical inexsufflation at effective settings, like 60 to minus 60, it clears both the left and right airways and prevents pneumonia. And allows us to extubate unweanable people because we can get their secretions out. Because of the availability of mechanical inexsufflation, because we extubate to full ventilatory support settings, which you can do with BiPAP, but it's not been done until recently with volume-targeted BiPAP. But even with that, it's not usually used optimally. No one needs a trach tube for being too weak to breathe from ventilatory pump failure, period. Proposition 2, as I've mentioned, muscle strengthening requires rest and exercise. And you don't do this with SIMV, PAV, low span bilevel, CPAP, or oxygen. In fact, oxygen is actually harmful for these patients, and it's counterproductive, and it's no substitute for non-invasive ventilatory support settings or mechanical insufflation exsufflation. Number 3, it's easier to extubate ventilator unweanable patients, even patients with no respiratory muscles whatsoever, than to remove the trach tubes of patients who are unweanable. But we've done that too. Just last year, we removed the trach tube of a 28-year-old with spinal muscular atrophy type 1 who's been 24-hour dependent on nasal ventilation since 8 months of age, was trached as an emergency at the age of 28. 6 months later, he wanted the trach out and we removed it, even though he doesn't have any muscle movement above or below the neck anywhere, except the use of one eye and the eyelid. And he wanted it removed in his house. And I have more faith in his nurse and his mother than a lot of other people. So we actually removed the trach tube in his house. I'm not recommending this to anyone else now. I make that clear. It's better to do this gradually. First of all, remove the trach tubes of patients who only use them overnight, then patients who need them overnight and some periods during the day. And eventually, like us, you should be able to remove the trach tubes of anybody who's 24-hour vent dependent and who should never have gotten them in the first place. So what is NIV? As I mentioned, NIV is CPAP and BiPAP that's usually not provided at full ventilatory support settings. The EPAP is bad for people with healthy lungs. It's fine if you're a neonate, it can help them. It can help people with COPD. It can help perhaps people on trach ventilation with no subglottic pressures. But EPAP is not only not helpful, it's a little bit harmful for patients with ventilatory pump failure. Why? It increases introthoracic pressure, it increases sensitivity of the myocardium to sympathetic stimulation and arrhythmias, decreases cardiac preload, stroke volumes and output, causes ventilator autocycling, disrupts sleep. It increases the risk of reflux and aspiration. It prevents active lung volume recruitment to maintain pulmonary compliance, to increase voice volume and cough flows, and it is uncomfortable. That was published by Dr. Cresciamano on bulbar ALS patients in 2016. And she's right. The EPAP is actually counterproductive. And the only reason it's being used is because doctors can bill for polysomnograms and for titrating away apneas and hypopneas that are completely useless. Because if you put the patient on non-invasive ventilatory support settings, there is no obstruction to the airway that will prevent the air from ventilating the lungs, and exhalation is passive. Now, what do I mean by that? We published a paper last year on morbidly obese people for whom CPAP of 30 centimeters of water was not normalizing their CO2. Their CO2s were 60 to 80. What we did was we turned off the EPAP and we put them on an active circuit and gave them and ventilated them at 35 to 55 centimeters of water pressure to a normal CO2, turned off the O2, and they no longer had obstructive apneas because a pressure of 50 centimeters is going to get past the obstruction, and the exhalation is passive. So again, these patients don't need EPAP. Is it harmful for them? Slightly, but it's also uncomfortable. There's some more reasons why the EPAP is not useful. So what is non-invasive ventilatory support settings? Okay, again, as I said, you can use high-span BiPAP at greater than 16 centimeters of water spans, generally 18 to 20. You can use intermittent positive pressure ventilatory support at a pressure assist control ventilation of about 20 centimeters of water, or you could use volume assist control ventilation. Now, for older adolescents and adults, I usually set a range of 650 to 1,400 or 1,500 milliliters. The brain, when the patients are sleeping, their brains control how much of that air they take with every insufflation, with every breath. And it ventilates them to usually a normal CO2, normal oxygen saturation. Like I said, and that's how we do it for like 3,000 patients at this point. I try to avoid BiPAP. Sometimes the patients actually get used to EPAP before, but I usually get my patients off of it and onto non-invasive ventilatory support settings. In 1952, they did not have iron lungs in Denmark, so they started putting patients in on trach tubes in patients. But in Ranchos Los Amigos in 1953, Dr. Affelt said the therapists and the patients were using the tubing from a Zephyr device and putting it by the patient's mouth, and the patient was getting deep breaths and stopped going into iron lungs. And he said the mouthpiece, you just hang it by the patients. They grip it with their lips when they want it, and when they don't want it, they let it go. It's just too simple. I don't know why we didn't think of this a long time ago. My mentor, Dr. Augusta Alba, in 1957, took 257 patients out of iron lungs, gave them a mouthpiece, used ventilatory support settings, which were pressures of 20 to 25 centimeters of water, There was no EPAP or PEEP on those Bantam ventilators. I published this in 1993. And in 1969, Dr. Alba began to remove the trach tubes of unweanable spinal cord patients and put them on mouthpiece ventilation day and night. In 1981, I was the first person to use nasal non-invasive ventilatory support. And I started putting it on patients in 1984, and we started extubating unweanable patients to it in 1988, after Jack Emerson gave me his inexiflator, the prototype of his cough assist or his mechanical insufflator exsufflator. And then 60 years after John Affeldt described mouthpiece ventilatory support, Respironics put a mouthpiece ventilatory support mode on their Trilogy ventilator. So doctors take a lot of time to learn things. In this case, it was 60 years. This is one of my patients who's 79 years old on 24-hour mouthpiece ventilation since 1954. She used the lip seal overnight. And my patients, some patients still use these lip seals, although most patients prefer nasal ventilatory support. 1981, there was no CPAP mask available. I took Foley catheters, put them in my nostrils, inflated the balloons, hooked myself up to a Monal D ventilator, ventilated my lungs. But I didn't think it would work overnight. I thought the air would go through the nose and out the mouth. 1984, this girl with under 200 milliliters of vital capacity, I was able to ventilate with nasal ventilatory support. That year, CPAP masks came on the market. We used them. We taped the holes shut to use an active circuit. Because you need to use non-vented interfaces when you use an active circuit, and you don't want EPAP, and that's what we did with her. And 2 years later, we extubated this MS patient who was unweanable. Her vital capacity had decreased to 250 milliliters. She hadn't slept in 3 days. I put her on nasal ventilatory support like this. After 3 days of not sleeping and being anxious, she immediately fell asleep. Her vital capacity was 250. I was giving her 900 milliliters through this mask, and I put a spirometer at the exhalation valve. She was exhaling back 750 milliliters of the 900 I was giving her. And in the morning, her vital capacity was 100 milliliters. I asked her why she was still using the nasal ventilation, and she said, because I can't breathe without it. She responded to ACTH treatments, and 4 days later, her vital capacity was 1.5 liters, and she came off the vent and went back home. So then I started thinking to myself, by the way, her mouth never closed. So I got a flashlight, I looked through her mouth, and I saw that the air was going through the nose, pushing the soft palate against the back of the tongue, sealing off the oropharynx, and she was getting almost all the air I was giving her, maintaining normal ventilation throughout sleep and normal saturation, oxygen saturation. So then I thought to myself, what about my patients with zero vital capacity on mask, on lip seal ventilation at night? I convinced 2 of them to let me watch them all night and to use nasal mask like this, and they never desaturated. In fact, the 2 of them never opened their mouths. They maintained, with zero vital capacity, normal ventilation all night long. But then I asked them if they wanted to continue nasal ventilation. They said, no, I want to go back to my lip seal, my mouthpiece ventilation. In 1988, 2 of my patients put a request in the newspapers for somebody to put the Coughflator back on the market. The Coughflator is mechanical inexsufflation. It gives you a deep breath, and the pressure drops to basically minus 55 centimeters of water, which is how it was used in the 1950s and 60s. Patients who had these things would never give them up because they knew that this was what was saving them from ever needing a trach tube and going into respiratory failure. We started using it. This was a 72-year-old woman, spinal cord injured, less than 200 milliliters of vital capacity, who was intubated. We extubated her, used this machine on her to clear her secretions, and managed her by non-invasive ventilation, and that's her. We extubated her to mouthpiece ventilation, to nasal ventilation. We let her choose what she wanted to use. She used mouthpiece during the day and nasal at night, and went home, and never got a trach, never had airway secretions because she never was intubated long enough to actually develop them very much. Now, this is a 54-year-old with Duchenne muscular dystrophy who's been on 24-hour ventilatory support for 30 years. He's never been to a hospital, and he's been married for 30 years, and that's his wife of 30 years. This was taken at their 25th wedding anniversary in 2018. I have 4 Duchenne patients over 50 years old and over 100, over 40. None of them have trach tubes. I tell them on first visit they will never need a trach tube, and don't ever let a doctor convince them to get one, or anyone in their family to put one in them. ALS patient, 24-hour nasal ventilation. Okay, fundamental principles to learn. Nobody ever needs a trach, as I mentioned. That you must distinguish simple. Okay, ventilatory pump failure is when the patient cannot maintain the CO2, and the CO2 goes up. And the CO2 can go up long before the oxygen saturation goes below normal, which is 95%. However, the CO2 can be normal and the saturation go down during colds when there are airway secretions or RSV or COVID. That is not a reason to think that they need a trach tube. What they need, first you need to ventilate them non-invasively, which in emergency rooms could be done with high-span BiPAP, although it's certainly not ideal. But you need to use the cough assist or the mechanical insufflation to try to get their saturation back to normal without giving them oxygen. If you're going to give these patients oxygen, they usually cycle downwards to the point where they stop breathing. Their CO2 goes through the roof. The CO2 of 50 can go to 180 in 20 minutes, and the pH dropped to 6.9, and the patient then gets intubated. And then when they're intubated, the doctors never shut off the oxygen. They think they're unweanable and need to be trached. Nobody, even if they are unweanable, needs to be trached. So that's what you got to understand. The big problem for people with Pompe's and other neuromuscular diseases is, like I said before, how do they get access to non-invasive ventilatory support when they're sick? How do they get access to a cough assist when they're sick? If their cough flows are over 270 liters a minute, they're not likely to need it when they're sick. But you've got to measure the cough flows and understand this. Babies typically get exsufflation flows with the cough assist of 50 to 70 liters a minute, which is little, which is why they end up getting intubated once a year when they have paradoxical breathing. After the age of 5 and they're able to cooperate with the cough assist, hospitalization rate is 2 per 50 years. And after the age of 10, it's 2 per 100 years, even for patients with 0 vital capacity and no muscle movement at all, because they're able to use the cough assist effectively to get flows of almost 400 liters a minute. Again, your critical care doctors do not understand this, your neurologists don't understand it, and your pulmonologists don't understand it. In fact, your physiatrists don't understand it. In fact, if you want to learn it, you're going to have to get my book, and stick it under the noses of your doctors to save your necks, literally and figuratively. And by the way, it's not just the necks of people with lysosomal storage disease. Any of you who have an elderly family member, 85 years old, let's say, do you know that women lose 1.2% of their vital capacity per year from the age of 20? Men lose 1% a year. By the time you're 85, you're down to less than half of what you had when you were young. Then you get a bronchitis or a kidney stone, you go to a hospital, and what do? They give you nothing to eat because they want to do imaging or surgeries. They wake you up all night to check vital signs, and you lie in a hospital bed. You lose 1 to 3% of vital capacity per day. After a week or two, your 85-year-old is going to get short of breath. Do they give you a mouthpiece with a ventilator delivering deep breaths or through the nose? No. They stick a tube through the nose or mouth into the airway, hook you up to the vent, knock you out, and then tell the family, well, your grandma had a good long life. She wouldn't want to live on a respirator with a tube through her neck, but we could put one there, or we could give her oxygen and morphine, which is a palliative death. They never tell you we could extubate her to a nasal ventilatory support and use the cough assist. They never tell you that. And frankly, not too many people are anxious to learn it. In the United States, there is absolutely no money in keeping anybody healthy, only in sticking tubes through people and doing surgeries that are often unnecessary, which is the subject of my next book, just to give you in fact, the next book is going to be titled, quote, "Why Don't You Want to Breathe?" unquote. The quote from one of my patients whose critical care doctors kept asking him why he didn't want to breathe. It's torturing him for 7 months, but I won't even go into that right now. Okay, so you need specifically trained respiratory therapists who know how to set people up on non-invasive ventilatory support. By the way, in New Jersey and in New York, we can get ventilators and cough assists to our patients within an hour or two, because the home care companies here, all of the therapists are trained by a therapist I've been working with since 1983. By the way, that's 1983, not 1883. And he trains all the therapists for the company, and the company knows that we have to get them what they need within an hour or two, or they end up in the hospital with a tube down their throats. So your local clinics need to be able to provide this knowledge to the local clinicians. And you got to try to find someone who's idealistic enough to spend the time to learn it, to maybe read a chapter or two from my book and save people's necks and lives. But it's not easy to find because doctors are very busy clicking on computers, and medicine in the United States is strictly a business. The consumers are the third-party payers, not the patients. Those are the ones you have to please. Airway tubes can be removed only when the oxygen saturation is normal in room air, even if the patient can't breathe at all. So in other words, we use the cough assist through the translaryngeal tube to clear the secretions and normalize the oxygen saturation. And with no supplemental oxygen and the saturation being 95 or more, and the patient fully alert, we extubate them to full non-invasive ventilatory support. That's how we do it. It's not rocket science. It works 100% of the time, but nobody else in the United States does what we do. Literally nobody else does it. It's just amazing. Okay, I'm sure I've gone over. I apologize. But as you see, I tell all these patients, no matter what their disease is, that they will never need a trach tube, and I've never been wrong. We've managed hundreds and hundreds of patients like this, 24-hour event dependent, and nobody has a trach tube, so they don't die from them. Okay?
Dr. Bach, we really appreciate this fantastic talk with the wonderful pictures. And this is the second time I'm listening to you. Every time I listen to you, I am amazed.